Hey everybody, this is Greg Oerther. I am the Behavioral Health Outreach Coordinator for UofL Health Peace Hospital. And it's great to hopefully see everybody attend this. We'll have everybody's cameras on at some point. I'm going to do a presentation today about how to talk to a mental health professional. Hopefully you guys can get some information from this that can benefit you in your work every day with how to interact with mental health professionals. I'm going to touch on a few topics. Please put some information in the chat. If you have questions or something you want me to clarify, I'll be responding in the chat, and then we'll have some time later where everybody will have their cameras on and we can ask some questions and do some dialogue back and forth. So hopefully this is positive for everybody. All right, so here we go. So how to talk to mental health professionals. Here's my information. Greg Oerther, I'm the Outreach Coordinator for Peace. And here we go. So when you're wanting to talk to mental health professionals, first thing to think about is you want to get consent from the guardian, right? So if you're going to be talking about one of your kiddos, you're going to call a hospital, you're going to talk to an outpatient provider, an in-home provider, any kind of provider that's working for a family, making sure that you get consent from the guardian, whether that's a release of information that's signed, or in the case of like a hospital, making sure you get verbal consent to be able to call that hospital and have the assessment set up. Make sure that you obtain consent from the family before you ever call a hospital or anybody regarding a child. So next piece that's really important is on providing collateral information. And what does that look like when you're talking to a mental health professional? So we want to have a historical perspective of the child. We want information about their living situation, their current living situation, any kind of trauma history, and then sources of strength. It's really important that we focus on a couple different things. One thing that you focus on is the most recent 72 hours, because when you're talking to like hospitals and stuff like that, we want to know for inpatient acute hospitalization, hey, what's the child's behavior been in the last 72 hours? Are they acutely psychotic? Are they acutely trying to hurt themselves, suicidal? Have they been acutely trying to hurt other people? Or was this something that mom reported happened 6 days ago, right? Because that's relevant, but it doesn't meet acute criteria within the last 72 hours. So that's an important piece to think about. So that timeliness and whatnot. Another big piece that's important when we're talking is to focus on some of the positives about the child and the client. So often we only talk about what's going on negatively with the child, the child or the client, and we miss out on, hey, what's going on? What are their strengths? Because sometimes we try very hard to take a strengths-based approach as a mental health professional. We want to really be able to work with a child and have, gain a connection and have a positive outcome. And so if all we see or hear is the negative, then it kind of becomes one-sided, makes it hard for us to do that. So when you're providing collateral information, make sure that you talk about what's happened in the last 72 hours. Make sure that you give us a little bit of historical information about what kind of treatment they've had, what their living situation is, what you know about their trauma history, and then give us a little information about their positives as well, right? Their sources of strength and whatnot. And then make sure that you're specific, right? Especially around if there's any kind of dangerous situations or if there's any kind of like statements about suicidal ideation or whatnot. What did they say? What exactly did they say? Because the language does matter. So those are the key points there. I want to talk for a little bit, just briefly, about what's called a system of care. And that's just understanding so that we're all on the same page language-wise about what are the different types of treatment the kids receive, what are the different levels of care that they may be receiving at a time. So there's lots of different levels of care. Kind of from the pyramid standpoint down, the highest level of care being acute inpatient treatment. So that's when somebody is inside a hospital, they're receiving 24-hour a day supervision, around the clock, 7 days a week, monitored by a physician, nursing staff, mental health techs, social workers, behavioral analysts, that whole bit, stuff that we do, for instance, at Peace Hospital. The next step is like a residential treatment, right? So that's where a child may be living 3, 6, 9, 12 months at a residential type facility where kids may be living with other kids who have similar situations and maybe living in a cottage situation. And then some kids might actually then be able to transition to live in like a foster care situation, but they're receiving very intensive services and whatnot. Another part of the system of care is partial hospitalization or day treatment, right? So that's where kids maybe come to Crossroads. That's the day treatment program that we offer at Peace. That's where they spend the bulk of their day in a treatment center. They're just not being held overnight. So that's where kids still have very acute issues. They're just maybe not as many safety issues that are requiring them to spend the evening in a hospital. So they need to be there for the day treatment program and whatnot. Then you may have heard of intensive outpatient or IOP services. Those services are usually 3 or 4 hours a day. For kids, sometimes these are after-school programs, and they're specifically designed usually to work on a targeted behavior. Maybe it's on substance abuse, maybe it's on relationship skill building, maybe it's on working with them on specific skills that they need to be able to communicate better, handle their emotions and whatnot. Those are short-term programs, so maybe we'll work with a child for 3 to 4 weeks in those levels of care, both partial hospitalization and intensive outpatient. Then you have the in-home therapy model, right? So in-home therapy is where the services come to the home. In-home therapy and the providers that provide that, they're going in their home. Typically, there's both a clinician and a case manager working together. They're going into the home several times a week. And it's intensive. Typically, these kinds of services last about 3 to 5 months, depending on what's going on. They're there to address safety issues that have occurred. So maybe it's a child who stepped out of a residential or stepped out of an acute inpatient setting. A lot of times these services are provided by the Cabinet for Health and Family Services. They have some in-home therapy programs that they use to reduce children being removed from their homes. So they do some like family preservation or stabilization programs. But there's also these services that are paid for by insurance and Medicaid. Then you have your traditional outpatient therapy setting, right, where the child goes to the outpatient therapy office once a week, twice a week, once every 2 weeks, once a month kind of thing. They may or may not see a psychiatrist at that point, and then a lot of times when they start these programs, they're involved in case management, right? So they have what's called TCM or targeted case management, kind of like the old Impact model or Impact Plus model that people may have known about who have some gray hair like me. And that's where they receive wraparound services. They do like monthly meetings. You all might be invited as school support to attend some of those kinds of meetings. And then they have the outpatient therapy without case management. And that's where they go see a therapist and they're working specifically on maybe a family relationship issue, treatment for like anxiety, depression, attention deficit disorder, something like that. They may or may not be seeing a psychiatrist at these services, and they may be on some medication, but they're fairly stable at this point. They're getting some ongoing services. So that's when we're talking about the different parts of system of care. This is part of just kind of identifying that for everybody. All right, so when you're talking to a mental health professional, it's very important to ask clarifying questions. If you don't understand what's being said, ask. The worst question is the question that's not asked. Sometimes clinicians talk in jargon or they'll talk in language and they'll use diagnostic terms. They'll say something was organic or biological. And what does that mean if you say something's organic? Or what does that mean if they're talking about a certain medication the child's on? Or maybe an evidence-based treatment model that someone is using to work with the child. If you don't know, ask, hey, what does that mean? What do those services look like? So that you can have a better understanding and be on the same page about the services. It's also important to know that you guys are going to know more information about families and the systems and the structures than a lot of the mental health counselors in the community working with the children. So you guys have histories with those families. Giving that information to a mental health professional is very important. A mental health professional really should be open ears to be like, hey, give me as much collateral information as you can so that I can figure out ways to engage with this family and figure out where they are. So I'm not reinventing the wheel with what you've tried, but also try new things that can also help supplement the strategies that are working for the child and the family. Okay. So, and a big part of that leads to this next slide, which is connection before change, right? So that's something I always have stressed when I've talked to clinicians throughout my professional career is you got to have a connection before you can see change, right? You have to have a connection that's established based on trust, based on relationship. And there's lots of different ways to gain that connection, right? It starts with, sometimes you're going to play some games with some kids. You're just going to kind of go back and forth. And a lot of times what that's about is setting boundaries, building trust. Are you going to play fair? what does this relationship look like in those ways? And then it's important for counselors to know, we need to know what kind of hobbies, what the likes, what the dislikes are about these kids, so that we know, hey, do they play soccer? Do they play football? Are they involved in chess club? Are they involved in scouts? What do they do with their time? And that helps us to kind of know and to branch out with different questions to ask, and then to look for different strengths to help support these kiddos. So another big part when you're dealing with mental health and you're dealing with treatment of kids is that everything has a time and a place, right? So what that means is that some topics, especially trauma, they're best handled in private, outside of school situations. These aren't really the best scenarios to go about in group settings. And it's also kind of like, it's like Pandora's box, right? So if you're at school and it's like a school-based therapist providing services, and they open this box and say, oh, start talking to me about this trauma situation, and this kid's emotions are just like running sky high because they're talking about this trauma. And then all of a sudden you got to say, okay, let me put a lid on that because my 45 minutes is up and you got to now go to math class. Well, if you've touched on a trauma subject, you can't just put that back in, right? Kids sometimes need time to process and hold that on emotionally. So knowing a time and place when you're talking about different issues that the child may have. So if you have a mental health professional is visiting your school and they're going to be talking to a kid, you can ask that. Say, hey, what do you guys, just, I don't need the nitty gritties about what you're talking about, but hey, there's certain topics that just be, we want to make sure that we're, that are they appropriate for what's going on in our school setting, especially if you have situations where you find that the child is escalating after their therapy sessions and they go into school settings and they're struggling. Well, that may be a conversation with the mental health professional about, hey, maybe some of those topics, maybe those some things need to be worked on outside the school setting. They're very important for that child to work on, but maybe the time and place needs to be worked on. So that's just something to think about when you're engaging with the mental health professional. Okay, so my next slide here is really about understanding of family systems. And that's, I'm going to kind of read a little bit from the slide and then talk about it in general. So most mental health professionals who treat kids are interested in treating the family systems as well. Some do this by incorporating family therapy into their treatment, and some do it by referring out to another provider to address family issues. So it's kind of a matter of preference, but when you're talking to a mental health professional, kind of understanding what their preference is, that's very important. So some clinicians are like, okay, I can see the child and their issues, and I can also work with the family and try to integrate those. Sometimes you may have an office of therapists where it's like, okay, I see the child and then someone else does the family sessions. That way there's not like these alignment issues where if you have to confront the child in the family session, or if the family's confronting the child about behaviors and the child looks to you to be like, get me out of this, you're my clinician. We don't want that to spill over and be difficult in your individual sessions because the family session was difficult. So sometimes, clinicians make decisions to, well, I'm doing the individual, but I have a colleague doing the family. Sometimes clinicians focus specifically on the child and their behavioral needs. These clinicians also focus on, they focus a lot of times on building coping skills and developing insight, right? So sometimes you're working specifically with the child on the way that they are interacting with peers at school, or the way that they are handling their anger and their feelings and their emotions, right? So that they're working specifically on skill sets that are transferable from whether it's family, whether it's school, whether it's community, right? And kind of understanding the system of origin of where your mental health professional is coming from. When I was doing a lot of therapy work with kids, I always would work with kids about, hey, there's three systems you engage with, right? You've got your family, you've got your school, and you've got your friends and community outside of that. So I'd always look at it from a perspective of, is my child or is my client, are they struggling in one of those areas, two of those areas, or all three of those areas? That would help me know as a mental health professional, okay, maybe what level of the system of care do they need to engage in? Like how much service do they need? And what kind of strengths and supports do they need in different areas? Because if there's one area that's going really well, what about that is causing that to go really well? And if there's one or two areas that are struggling, well, let's see if we can take and replicate some of the strengths that are happening in one of those success areas and move those strengths and position ourselves to help the child in those areas. So when you're communicating with the mental health professional, kind of understanding what their understanding of how those systems work, whether it's within the family or within the community or within the school or whatever different structures that affect the child. And then understanding the approach that the clinician is taking as far as the family. And this can get real complicated. We have a bunch of blended families. We have multiple, maybe we have kids that live with one parent part of the time, live with another parent part of the time, different rules in their house, different settings and whatnot. And we have to integrate a lot of those behaviors and skills. So those are things to think about and to be engaged with. And those topics should be open for discussion when you're talking to the mental health professional. Okay, this is a little bit more of a technical slide. So that's about when you're talking to mental health professionals, are they talking about the function of the behavior or are they talking about the diagnosis, right? So some clinicians, they focus on the diagnosis. They focus on the criteria about the diagnosis, like what DSM-5 diagnosis is it? They do a lot of testing. A lot of psychologists do that, right? And it's really about, okay, let's do a great assessment to figure out, okay, this child definitely meets these criteria for ADHD, or they meet these criteria for a mood disorder or conduct disorder, or what type of behavioral health issue do they have? And then other clinicians focus more on the root causes of behavior. So a lot of behavioral analysts, they focus a lot of times on this model. So they focus on like, okay, so the child's doing this behavior, and then what was the antecedent? Like, okay, this behavior happens. What was immediately happening before? What was the stimulus that was presented to the child? And then how did the child respond, right? So it's kind of a lot of, I always talk about, it's kind of like the Pavlov's dogs experiments, right? It's more function of behavior. So it's not so much about the diagnostic piece, which is like following the DSM, but it's more about, okay, this child's behavior is a certain way. We add a stimulus, the child behaves a certain way. We change that stimulus, how does the child behave? So understanding kind of which framework. And then there's a lot of clinicians that implement a combination of these approaches. They work on developing a functional understanding of the behavior while also seeing how the behavior fits within a diagnostic framework, right? So it's like, okay, we know the child is struggling with their attention deficit. We know that they're impulsive. We know that they struggle with transitions. So then it becomes, okay, we figured that out. So we know maybe we need to look at a medication piece to help them with their impulsivity, with their attention. But we also need to work on a behavioral piece to be like, okay, with what kind of prompts do we need to do to help them with transitions? What kind of, if they're a little kiddo, what kind of visual cues can we give them about, okay, this is the time we're going to do this behavior. This is the time we're going to do this behavior. Charts are real good for these kinds of kids to help them stay organized and whatnot. So lots of different age kids. What's going to work for little kids is going to do something totally different for a middle school kid, totally different for a high school kid. But understanding where the approach is coming from the mental health professional, that's very important in understanding what they're working on with the child and how you can help support them and what they're trying to engage the child in. So I hope that's helpful. Again, any questions? If you're having them, throw them in the chat. If I can answer them, I will. I'll do the best I can with that. And hopefully you're getting something out of this. So another big piece when we're talking about this whole how to engage with mental health professionals is evidence-based practice, right? So 10 years ago, 15 years ago, when the first beginnings of evidence-based practice started out, are we using like a cognitive behavioral approach? Are we using like a parent-child interactive approach? Are we using a motivational interviewing approach, right? So there's different types of skills and about how we're working with kids. And then it's become even more specific as far as, hey, not just the framework, right? Our old Albert Ellis discussions versus our Fritz Perls and that stuff from all of our years of college. But it's like, okay, are there actual skill sets that we're working with, right? For instance, like parent-child interactive therapy. We've got the pride skills, the praise, reflect, imitate, describe, and use enthusiasm, right? So we have these specific skills that we're trying to measure that we're, say, hey, are we doing these skills when we're interacting with the kiddos? So some clinicians are very focused on, I'm going to use one set of skills. I'm going to use a trauma-focused CBT model, cognitive behavioral therapy model. And that works great. That's what they're comfortable with. It's a great skill set. may or may not work for that child, but it's a great set of controlled behaviors that work. It's a skill tested approach. Sometimes people use like a motivational interviewing approach. And these approaches, you can look them all up. You can study these different approaches. It just has different ways to approach kids. So talking to the mental health professional about, hey, what evidence-based models are you using, right? Whether it's like a teenager and they're struggling with substance use issues. And so maybe we're using the 7 challenges model. Well, what does that mean? So if you're going to be speaking to the mental health professional and they talk about this is the evidence-based practice we're using, take a little bit of time to look up what that is and find out where the child is in that process of that modality, right? So that you can help understand, okay, this is where we're talking to, this is where this child is coming from. This is how the mental health professional is progressing them, so that you can have real discussions if there's ever like a treatment team meeting about, hey, we're seeing the child do well, but they're stuck here, right? Or we're seeing the child struggle with these types of interactions. We're seeing the child struggle when this kind of stimulus is presented to them, or when we're asking them to do this much work, or maybe it's this time of the day that they're struggling. All those pieces of information help, because it helps us know maybe they're on a Focalin or an Adderall in the morning, but maybe it's on 25 milligrams, and maybe we need to add something at noon, right? Or maybe they're not sleeping as well because they're struggling in the mornings. And so you're getting that kind of information that can be really helpful to say, okay, maybe we need to add a melatonin or something in the evening to help a child sleep. So there's lots of different things that can help in these conversations. And so being able to talk about what's going on with the child in relation to what type of treatment modality they're using can be very, very helpful. So next piece is on triggers and coping skills. Something I wanted to touch base about is that, so clinicians work with their clients on understanding triggers. Clients are triggered by different stimulus and by different environments. Clients may be able to manage a certain stimulus in a school setting, but not at home, or vice versa. So you know how I kind of talked about those 3 different settings: community, school, and home. And then kids get triggered different ways, right? Kids might be triggered by older kids who pick on them. So they may struggle really on the bus. They may struggle in the hallway transitioning. They may struggle at like lunch if there's, lots of different kids. Some kids may struggle just by lots of stimulus, right? So the hallway, again, may be a really big struggle for them, or the lack of structure on a bus might be a big struggle for them. They may need to sit in a certain place in the classroom to do better and whatnot. And these are all kind of basic things that you see, but understanding the basics helps you to, if you apply those same skills and those same understandings as you move forward, you can have and you take that insight that you gain by watching the child, and you can help share that information with the mental health professional when you're talking about triggers and coping skills. So clinicians, they work with clients to develop coping skills, and they'll want the client to try these different skills out. So making sure that you're talking to the clinicians about what coping skills they're working with the child to try, so that they can help, you guys can help prompt the kids to use those coping skills at times of stress, right? So you would want to know if your mental health professional is working with the child on, if they start to feel overwhelmed or uncomfortable and they decide, okay, I'm going to put my head down on the desk and I'm going to like close my eyes and put my head down. Well, that might be a great coping skill the clinician's working on. But if a teacher doesn't know that that's the clinician's talking to the child about doing that, and they say, you need to put your head up, you need to pay attention, not realizing that that's a coping skill that the child's using. So that could be just a basic example of how not communicating appropriately can cause a problem, where a child's trying to do something appropriate, but they get fussed at for it. But if the teacher's doing the right thing too, because they're trying to get the child to pay attention to the learning that needs to be occurring and the lesson plan, but the child's taking an emotional break. So we need to be on the same page. We need to be communicating with our mental health professionals about these different coping skills they might be using, so that everybody's on the same page that, when this child needs to take a break, or if you see the child frustrated as a teacher, the teacher can go and just tap the desk and put your head down, right? Or it can be they talk about it saying, hey, when you start to get frustrated, just put your pencil down, whatever, and just put your head down. And I know, hey, you're just needing a break right now, right? So the more that they know about what's going on coping skills wise, the more that they are engaged with the whole treatment process, it helps the child have a more successful outcome. So ways to support coping skills. I talked about some of these in the last couple minutes. So prompting the child to use their coping skills may look different as the child ages and has different developmental levels, right? So it may look different. Like the little kiddos, you might need to walk up to them, tap the desk, or help them just know, hey, time to put their head down. Older skills, it may work. It may look different. It may just be like you can glance at them and they'll know, okay, I need to take a chill, right? And I need to do what I need to do. Regardless, whether you're using proximity controls, whether you're using like a physical touch item to like say, hey, let's put our head down here, whether you're removing a child from a situation, if you need to do that. The most important thing is to continue to try to stay positive and stay supportive of the child. Understand that you're going to take 2 steps forward and 1 step back, right? The process is it's a process of incremental positive development. It's not going to get fixed in a day, right? We're not going to take the child who's struggling, that's on your radar as a kid who needs lots of mental health supports and it's getting access to services in the community, and the next day they're going to be golden with, you know, getting straight A's and having no behavioral issues, right? It's not how it works. We all know that. It's about how do we make incremental changes? How do we help them feel success? How do we help them realize that school can be a positive place for them, so that they can feel connected to school and that they're going to have a better chance to succeed and graduate, right? Because connection becomes change, right? So you feel connected because you feel successful. Once you can feel connected and feel success and feel like it's okay to fail and it's okay to make mistakes, but that I'm going to put in effort and try, and that we have a connection around that, then I'm going to have a better chance to stay engaged in the whole educational process, which is going to help the school get better outcomes, and it's going to help the children get individual better outcomes for their lives, which is going to help all of us. So communicating with our mental health professionals in the community about what's working, what kind of skills are working, what's not working, is just really important. Okay. Next piece on this, when you're talking to mental health professionals, is about behavioral changes versus medication. So many behaviors can be changed with therapeutic skills that help to lead to developing insight on behalf of the child, right? So they learn some self-regulation, they learn to make better choices, they learn to pick their friends better, they learn to stay away from choices around drugs and alcohol as they're older, they learn to take a chance and join a club or an activity or something like that, right? And then they become engaged, they become more invested. But sometimes medication is needed to help the child feel success, right? A lot of times stimulant medication, for example, can help a child focus, whether that's Focalin, Adderall, Ritalin, all the different types of Strattera, all the different types of medications we're talking about in that realm. This medication and this focus, it helps them to gain insight and confidence, right? So the medication doesn't have to be a long-term, some kids need to stay on it forever, right? Or at least while they're in school, because it's just organically, biologically, what's going on with them. This medication helps them stay focused. Some kids, it can just be, hey, they need to feel some success, right? So the child, as they feel success, and as they start to gain more self-control and they gain more behavioral modification changes for themselves, then they can come off some of the stimulant medication because they've been able to engage in their coping skills are at a higher level where they're able to tap into those coping skills and engage better. At times where you guys are going to hopefully come in important for the mental health professionals is school staff may be asked to complete observations and document their experiences with the child to help the prescriber know what's working. So a mental health professional that's working in the community at an agency is going to be in touch with you all, or should be in touch with you all, saying, hey guys, we need Vanderbilts, we need Barclays, we need these behavioral forms filled out that are just ask the teachers to fill these forms out to show what's going on with the child behaviorally. That information is then processed by the mental health folks on the outside and the physicians, and medication adjustments can occur based on some of that information. So it's very important that we stay connected, that we stay engaged, so that we can help our mental health folks help the kids. So another piece about this with communicating with a mental health professional is to know that it is an ongoing communication piece, right? It's not okay, I checked the box, I talked to the child's mental health provider, right? Or the mental health provider saying, oh, I checked the box, I talked to the child's school, that's part of our contract with the Cabinet of Health and Family Services if we're providing in-home therapy, that I need to touch base with the school, check that box. That doesn't help kids, right? What helps kids is ongoing communication. And the way we do that is by, just like anything, we would set up a plan with how that communication is going to look, right? Getting on the same page about what ongoing communication looks like with the mental health professional. That's important. It's appropriate to ask to be invited to treatment team meetings. It's appropriate to, if you're going to have like meetings and the child's working with the provider long-term, talking to the family, getting that consent to say, hey, can we invite the provider to get information about how the child's progressing outside of the school setting. Some of the providers are going to want to talk to you about a phone. You guys can set up, say, hey, let's have a monthly update. Sometimes they're going to want to do something in writing, where it's like, hey, this is what's going on with the child, that they can blast out to maybe the social worker, maybe to you guys at the school, maybe to whoever needs that information, depending on what part of the system of care they're engaged in. But knowing that it's important when a child's engaged with a mental health professional and you get consent from the family to talk to that professional about, hey, let's make communication, but let's make ongoing communication a priority. That way we know that the child's still getting the services that they need, that they're engaged in these services, because too often it's like, oh, child started therapy. The school thinks, oh, the child's engaged in therapy, but the therapy happened once or twice, therapy stopped, child's behaviors escalate. We're like, what's going on? This therapy's not working, but there's no ongoing communication. So there's not a communication path with mom or dad saying, hey, let's try to get the child back engaged with that clinician. And it's also important, if that relationship isn't working for the child or the family with the outpatient, with the community provider, to talk to the family and know a bunch of different community providers, so that you can say, hey, here's some options for you, family, if this relationship you have isn't working the best for your child. So those kinds of pieces of communication are just really important. So I went through that quick. There's a lot of information there. I hope it's helpful to you. Mental health professionals, you guys, lots of you all here, most of you all here are counselors, you're mental health professionals yourselves, or you have mental health professionals within your school. But communicating with people, asking questions, asking clarifying questions, that stuff's very, very important to help our kids. It takes time, it takes energy. None of us have enough time in the day, but getting the information and getting on the same page can really help you decide to figure out also, hey, these are the mental health professionals that do a great job, that work great with our kids, so that you can help refer to those folks, so that you're getting helping your kids get good and positive outcomes. So hope everybody can flip their camera on. Anybody want to ask any questions? I will be here and we will do that. Again, thanks for attending. Here's my email address. It's gregory.oerther@uoflhealth.org. Reach out to me anytime. If I can ever be of assistance in any way, please do that. I'm going to end this recording at this point.